Өнөөдрийн хурлын 2 дугаар өдрийн нээлтийг миний бие. За эмгэг судлалын лабораторийн чанарын хяналт аюулгүй баталгаа ба уропатологи сэдвтэй вебинар хурлын маань өнөөдөр 2 дугаар өдөр үргэлжилж байна. За өнөөдрийн үед бол бүгдээрээ уропатологийн онцлогоо сэдвт илтгэлүүдийг сонсохоор байгаа. За ингээд эхний илтгэгч маань Солонгос улсаас Ги Явон профессор байгаа. За профессорын маань хувьд бол онлайн оролцож болохгүй, амжихгүй болсон учраас тэрээр видео бичлэгээ илгээсэн байгаа. За түүний танилцуулах одоо илтгэлийн сэдэв бол ерөнхийдлийн хавдруудын одоо вариантууд буюу хувилбарууд сэдвтэй ийм байгаа. За Гиомон профессор маань хувьд бол Samsung одоо ангаах ухааны төвийн профессор байгаа. За тэрээр генетоюринary шээс дамжуулах замын патологийн чиглэлээр одоо нарийсан. За Солонгосынхоо патологчдын нийгэмлэгийн за генетоюринary одоо патологийн хэсгийн ахлагч ийм хүн байгаа. За ингээд Гиомон профессорын лекцийг бүгдээрээ сонсё.
I am Ki Young-won in Songyungan University of South Korea, and it's a great honor to be invited to this international conference. And today I'd like to talk about the variants of the urothelial carcinoma. Urothelial cells were previously called as transitional cells, and they dropped their names. So, non-neoplastic urothelial cells can undergo a variety of morphological alteration, leading to squamous or glandular cancer. This phenomenon is not limited to non-neoplastic cells and also can be found in cancer cells with resultant variant histology. So, urothelial carcinoma can show diverse histological variants, including these types, starting from infiltrating urothelial carcinoma with squamous differentiation, glandular differentiation, to repeat variant and clear cell variant. And in this talk, I would like to briefly review each of these variants, comment on the implications in the diagnosis and patient management. Squamous differentiation can be found in up to 40% of urothelial carcinoma in urinary bladder, and carcinizing metaplasia or squamous cell carcinoma in situ is not important in the pathogenesis. It is usually associated with moderately or poorly differentiated form of urothelial carcinoma, and resistance to chemotherapy or radiotherapy has been reported, but the data are limited. And recently, squamous morphology has been linked to basal subtype by molecular classification. In this regard, association with poor prognosis is also suspected, but it has not been verified either. The diagnosis of this morphology. Several points need to be remembered. Firstly, careful sampling is mandatory since coexistence of urothelial carcinoma in situ or invasive is required for the diagnosis. If the tumor is composed completely of squamous component, then the diagnosis should be pure squamous cell carcinoma. The prominent cytoplasmic eosinophilia is not sufficient, and definite squamous features are needed. Immunohistochemical staining with these antibodies can be used for the differential diagnosis between urocellular component and squamous differentiation. The immunoactivity is not a definite criterion for the distinction. Keratin polyps found indicating squamous differentiation. Mild cytologic expansion with eosinophilia that does not qualify for squamous differentiation, and which in this case could be labeled by Uropathology 3, which is a urocellular marker. Glandular differentiation is less common than squamous differentiation and can be found in even well-differentiated carcinoma, in contrast to squamous differentiation, which is usually found in moderately or poorly differentiated form of urocellular carcinoma. It is of most commonly enteric morphology, and association with poor prognosis is also suggested as in squamous differentiation, but again has not been completely verified. The differential diagnosis includes benign conditions such as cystitis glandularis and malignant tumor or urocellular carcinoma with lesion or cystic space, and other cancers such as metastatic adenocarcinoma. In fact, in tumors with glandular differentiation found in urinary bladder, metastatic adenocarcinoma is more common than urocellular carcinoma with glandular differentiation. Here we see a urocellular carcinoma with glandular differentiation, in contrast to urocellular carcinoma with cystic space and metastatic adenocarcinoma. Urocellular carcinoma with trophoblastic differentiation can be found in a wide spectrum, spanning from urocellular carcinoma with human chorionic gonadotropin immunoreactivity, urocellular carcinoma with synthetic trophoblastic giant cells, and choriocarcinoma. Pathogenesis remains unresolved and may involve metaplasia of certain immature cells or primitive blasts which may retain capacity for pluripotential development. Synthesiotrophoblastic giant cells can be found in up to 12% of urocellular carcinoma, according to different series, and the incidence of positive HCG immunostaining may be higher and can be found in up to 35%. Expression of beta-HCG has shown association with higher grade or stage. Large pleomorphic cells and some giant cells are found, which show immunoreactivity to HCG. It is characterized by less of relatively bland tumor cells, but is clinically aggressive with frequent presentation in high stages. More atypical tumor cells can be found in deep areas, and sometimes conventional urocellular component is not present. Most cells are relatively bland cytologically. Several benign conditions such as bone bruise stress, inverted papilloma, cystitis glandularis or cystica, Reproducing adenoma come into differential diagnosis. But these usually show circumscribed region with no stromal response. Where circumscribed region of fungus less, listed variant of urocellular carcinoma shows irregular infiltration to tumor cell less, which are composed of relatively homogeneous tumor cells without significant cytologic atypia. Microcystic variant is characterized by tumor-less gland-like lumina, lined by urocellular cells, which are flat or plugged or usually cytologically bland. Lumina or cytoplasmic lesion is frequently found as tumor response is variable but usually absent. The criterion for diagnosing the variant is not clearly defined, but some authors suggested 25%. Differential diagnosis includes benign lesions such as cystatic cystica and nephrogenic adenoma. Atypical characteristics including invasive pattern is factor for differential diagnosis. And in nephrogenic adenoma, ANA, CR staining is also factor for the differential diagnosis. Clinically, this variant is not very different from conventional urocellular carcinoma. Small variably sized like structures are found and show irregular distribution. Lining cells are not highly atypical, but show mild variation in thickness and shape. Micropathology variant is a well-recognized variant with incidence of about 1 to 2% of all urocellular carcinoma. It was initially defined as resembling papillary serous carcinoma of ovary. It shows small tight tumor cell nests or aggregates in lacunar space, which are sometimes architectural, but often intravascular spaces constituting intravascular invasion. Frequent OP2 expression is found. Since it is a significant unfavorable prognostic feature, any amount of this component should be reported. And since this tumor is almost always deeply invasive, if a biopsy is superficial without proper muscle invasion, deeper tissue is recommended. Oil cystectomy with adjunctive chemotherapy is advocated in some institutions in cases without proper muscle invasion. The differential diagnosis includes metastasis, considering that similar tumor can be found in other organs, including ovary. Numerous small less-chilled tumor cells are infiltrating into proper muscle and contained in a lacunar-like space, some of which are lining by D240, which is a lymphatic marker. In lymphoepithelioma-like carcinoma, we can see syncytial tumor cells in mixed inflammatory background. This tumor is not associated with Epstein-Barr virus, in contrast to similar appearing tumors in other organs such as nasopharynx. Differential diagnosis includes benign or malignant lesion with prominent inflammatory infection, such as lymphoma, florid cystitis, or poorly differentiated urocellular carcinoma with lymphoblastoma. Favorable outcome is expected in pure or predominantly lymphoepithelioma-like carcinoma, which means over 50% of the compound. But this has been recently challenged by one study which reported similar outcome as conventional urocellular carcinoma. In this slide, we can see synthetic tumor cells in the background of mixed inflammation. In plasmacytoid variant, solitary tumor cells show infiltrative growth in loose or mixed stroma. The name viscous variant is also suggested for similar growth pattern with tumor cells in plasmacytoid or signaling cell-like morphology. Tumor cells are occasionally positive for CD138, which is a marker for plasma cells, but this tumor has no special relationship with plasma cells other than superficial morphological resemblance. And this tumor is almost invariably associated with poor prognosis. Differential diagnosis includes a variety of tumors which can show infiltration of individual tumor cells such as plasmacytoma, plasmacytoid lymphoma, adenocarcinoma, especially signaling carcinoma, and malignant melanoma or metastatic carcinoma or similar morphology. Single scattered small cells are infiltrating in subepithelial connective tissue, and individual tumor cells in this case show slightly eccentric nuclei with plasmacytoid morphology. Immunostaining for CD138 was diffusely positive in this case. Sarcomatoid differentiation can be found in urocellular carcinoma and most commonly resemble malignant fibrous sarcoma or undifferentiated sarcoma. Heterologous differentiation can be found frequently in the form of osteosarcomatous or chondrosarcomatous or rhabdomyosarcomatous areas. Previous history of carcinoma with radiotherapy or chemotherapy is a major risk factor, and treatment is usually different from sarcoma. It is associated with poor prognosis even after adjusting for stages. Several benign or malignant conditions can be considered in the differential diagnosis, including pseudosarcomatous myofibroblastic proliferation, which encompasses post-operative spindle cell nodule and pseudotumor, urocellular carcinoma with pseudosarcomatous tumor, or osseous chondral metaplasia, and sarcoma such as leiomyosarcoma and others. Immunohistochemistry can aid in the differential diagnosis, but some pitfalls should be kept in mind, such as not unusual cytokeratin positivity in pseudosarcomatous myofibroblastic proliferation, actin expression in sarcomatoid carcinoma, and P63 positivity in leiomyosarcoma. And hyperstable cells are present, which are labeled by epithelial marker and P63. Smooth expression is also found. ЧАНАРЫN variant was initially identified as undifferentiated carcinoma and resembled ЧАНАРЫN carcinoma of lung. It shows ЧАNARЫN tumor cells with marked pleomorphism, and showing transition from atypical mononuclear cells to ЧАНАRЫN cells. Immunohistochemistry reveals positivity both for cytokeratin and iron. And for prognosis is the rule for this tumor. Large tumor cells are found with ample cytoplasm and sometimes vertical nuclei, which show significant pleomorphism. Lipoid cell variant in urocellular carcinoma showing large lipoblast-like cells with repeat vacuoles can be associated with other variants such as plasmacytoid, micropathology variant, and shows progressive clinical course. The tumor cells have atypical nuclei and large lipid vacuoles. Sometimes urocellular carcinoma can harbor clear cells, which may instigate diagnostic confusion with other tumors such as clear cell adenocarcinoma or metastatic renal cell carcinoma or invasion from prostatic cancer. Infiltrating tumor cells focally show clear cytoplasm, which may mean renal cell carcinoma or clear cell adenocarcinoma with tubulo-papillary architecture and focal pulmonary appearance. Carcinoma can be found in urocellular carcinoma and can be indistinguishable from pulmonary counterpart. Immunohistochemistry is also similar with expression of neuroendocrine markers and TTF1. Urocellular carcinoma can be found to cause images, and the two components are thought to be of clonal origin. Even focal presence of small cell component tends poor prognosis and thus merit the designation as small cell carcinoma. Hyperchromatic tumor cells diffusely infiltrate peripheral layer and are positive for neuroendocrine marker and TTF1. Sometimes the urocellular carcinoma can present with small tube-like tumor cell nests in pure form or mixed with nested variant. This morphology has not been attributed biologic significance other than potential for diagnostic confusion with non-nucleatic lesions such as leukocytic adenoma. Small cyst or tube-like structures are found irregularly infiltrating stroma and between muscle fibers. Constituent cells do not show significant ATP. Though the morphology found in a variety of other carcinoma is also present in urocellular carcinoma, which appears as eosinophilic bodies composed of intermediate filaments. Progressive clinical course is double as in other organs. Atypical nuclei are found adjacent to ample cytoplasm, which has round eosinophilic body labeled by maintained immune state. Variant cells can be found in a variety of situations in urocellular carcinoma. Firstly, the namesake giant cell adenocarcinoma with marked pleomorphism. And sometimes trophoblastic giant cells can be present in urocellular carcinoma. Sarcomatoid carcinoma can contain anaplastic spindle cell giant cells. Osteoclastic-like cells are occasionally found, and treatment such as BCG or transurethral resection can lead to the presence of giant cells. We can see the foreign body type giant cells associated with tumor, and osteoclastic-like cells are relatively bland in morphology. Giant cell carcinoma can have highly atypical giant cells, and trophoblastic giant cells can also be present in urocellular carcinoma. Sometimes urocellular carcinoma shows unusual stromal reaction, which may lead to confusion with sarcomatoid carcinoma. Reaction can be prominent, mimicking with sarcomatoid carcinoma. And cells or cartilaginous metaplasma can also be present, sometimes with osteoclast type giant cells. Prominent lymphoid infiltrate is also occasionally found. A few hyperchromatic spindle cells do not qualify as sarcomatoid carcinoma. And sometimes cells or cartilaginous metaplasia can be found in the stroma of urocellular carcinoma. But considering the blend morphology of the stromal cells, it does not represent the sarcomatoid carcinoma. And so in summary, there are some variants with deceptively benign appearance which may cause diagnostic confusion, such as the scale variant, microshifted variant, tubular variant, and inverted cross pattern. And variants can be characterized by unusual cytoplasmic features, such as clear cells, plasmacytoid appearance, lactoid or lipoid morphology. And many variants are associated with aggressive clinical course, including urocellular carcinoid squamous or glandular differentiations, nested variant, to plus H variant, lactoid variant, and lipoid variant. Lymphoepithelioma-like variant can show a favorable therapeutic response, and clinical significance is not determined for some variants, such as urocellular carcinoma with small tubules, urocellular carcinoma with clear cells, and microcytic variant. And prognosis, especially for small cell carcinoma or sarcomatoid variant. The variant morphology can be present in pure form, but more often is mixed with conventional urocellular carcinoma, and different cutoff has been proposed for some variants. In small cell carcinoma, any proportion qualifies a tumor as small cell carcinoma. Lymphoepithelioma-like variant is usually defined as containing more than 50% to qualify as one. For micropapillary variant, from less than 10% is used in most cases. And some methods will propose 25% for microcystic variant. In final summary, urocellular carcinoma can show a wide variety of growth pattern and divergent differentiation. And the recognition of these variants is important for correct diagnosis, optimal treatment, and accurate prognostication. It is necessary to document the presence of these variant morphology and to quantify the amount. And with this, I close my talk, and thank you very much for your attention. I am 이영권 in
За дараагийн одоо илтгэгчийн маань сэдв болол шийдний цитологийн талаар харуулж одоо та бүхэнд танилцуулна. За түүний одоо онцлогооны талаар та бүхэнд танилцуулах болно. За профессорын маань хувьд бол Хироюки Осаки багш байгаа. За түүний хувьд бол Кобе их сургуулийн эрүүл мэндийн шинжилгээ ухааны одоо салбар сургуулийн ийм профессор байгаа. За тэрээр та бүхэн шийдний цитолог, за түүний одоо онцлогооны үүргийн талаар танилцуулах болно. За Professor Osaki, are you there?
Hello.
Hello, Professor.
Can you hear me?
Yes. So we are gonna start. The first of all, I would like to appreciate for your joining us. And yesterday we had Yesterday, we had the first session called Quality Control Assurance in Pathology. And today we are continuing our session into Uropathology Essentials. So we are appreciate for your participation in our webinar conference. So today, usually the doctors pathologists from all over the country, especially from provinces. So the doctors from National Pathology Center are gathering in the meeting room and watching your lecture. So we are going to start your lecture from now. Would you like to greet for our colleagues? 挨拶しますか、先生。聞こえます。はい。聞こえますか。はい。
please、通訳してもらっていいですか、日本語。
わかりました。
今日はこのような機会をいただきありがとうございます。
За өнөөдөр ингээд энэхүү хурлын үйл ажиллагаанд оролцуулж намайг урьж агаад боломж олгосонд баярлалаа.
私は今後あなた方と一緒に共同研究をしたいと思いますので、よろしくお願いします。
За тэгээд энэ удаад та бүхэнтэй хамтраад энэхүү одоо вебинараар дамжуулан та бүхэнтэй бас ингээд судалгааны саналаад ярилцах болсондоо баяртай байна.
それではよろしくお願いします。
よろしくお願いします。За Hiroki Osaki багшийн ихтгэлийг тавиад өгөөрэй.
Ladies and gentlemen, first of all, I would like to say thanks to all of you who are participating in this wonderful opportunity. And as a matter of course, I would like to express special thanks for this opportunity to be a part of this program. My name is Hiroki Osaki. I am an associate professor at Kobe University, Graduate School of Health Sciences. And my specialty is site pathology. I have over 30 years of experience in site pathology, as well as various levels of education. As you can see here, my presentation today is to introduce urine cytology with the primary objective. Because I have heard that urine cytology is not widely used in Mongolia. Hopefully, after my talk, many of you will be interested in learning more about urinary site pathology. Let's get started. This slide compares bladder cancer mortality in each country. According to 2016 data, bladder cancer mortality in Mongolia is about 1/10 that of Japan. As a result, interest in urine cytology may be low in Mongolia. However, in the future, the mortality of bladder cancer will surely increase in your country as well. Therefore, we consider that urine cytology will become more critical in the future in your country. Let's look at today's table of contents. As you can see here is what I'm going to talk about in this presentation. I have divided my speech into 3 parts. First, urine cytology, the overview. I will explain the history, advantages, and disadvantages of urine cytology. Second, the Paris system, which has been established in 2016. Here, I'll talk about the categories and the criteria of the Paris system. And in the end, I will talk about sample preparation. My presentation will finish in about 30 minutes, I presume. First, urine cytology overview. It goes without saying, urine cytology is a diagnostic test for urinary tract cancer. And it was introduced in 1945 by Dr. Papanikolaou as a modern cytological examination. Since then, urine cytology has done much to promote the use of this method for diagnostic purpose, including non-invasive and inexpensive tool for detecting high-grade urothelial carcinoma. In this slide, I will show you the advantages and disadvantages points of urine cytology. The advantage points of urine cytology are non-invasive and inexpensive, as I said earlier. Moreover, it is high sensitivity and high specificity in detecting HGUC. On the other hand, the disadvantage points are low sensitivity and specificity in detecting low-grade urothelial carcinoma, LGUC. And it had no standard method regarding sample preparation, diagnostic criteria, and reporting system. That is always a tough problem in a clinical laboratory environment. As a result, that provides causes an inter-laboratory discrepancy in diagnostic accuracy. Therefore, the PARIS system was published in 2016 as a standard reporting system, including categories and diagnostic criteria. In the first place, I should point out that low-grade urothelial carcinoma and high-grade urothelial carcinoma are different tumors. As you can see this table from Dr. Barkan's paper, the frequency of LGUC is 80%, whereas HGUC is 20%. In gene abnormality, low-grade urothelial carcinoma is FGFR3, whereas high-grade urothelial carcinoma is P55. Although recurrence is in both, invasion is only HGUC. Therefore, HGUC is a poor prognosis, whereas LGUC is a good one. In the bottom column, cellular atypia, LGUC is mild, but HGUC is much more severe. As a result, we can detect easily HGUC cells in urine cytology, but difficult to detect cells from LGUC regions. Consequently, we must detect HGUC with a poor prognosis using urine cytology. Next, let me explain about the PARIS system. As I said to you earlier that the PARIS system was published in 2016 with the aim of a global standard reporting system, including diagnostic categories and cytomorphology criteria. The feature of the PARIS system is that it specializes in detecting HGUC, which is said to be a poor prognosis. To briefly summarize, in the PARIS system, the following 7 categories could be classified. First, non-diagnostic or unsatisfactory. This category is when the epithelial cell appearance is scarce or there is remarkable cell degeneration. Negative for HGUC. The important thing here is that it's negative regarding only HGUC. Therefore, it cannot be denied the existence of LGUC. Atypical urocellular cells, AUC. This category is urocellular cells that are difficult to distinguish between benign and malignant lesions. Suspicious for HGUC. HGUC. Low-grade urocellular neoplasia, LGAN. This category includes LGUC and benign tumors, urocellular papilloma in particular. Other malignancies. This category includes squamous cell carcinoma, other carcinoma, and metastatic cancer from other organs. This diagnostic flowchart is quoted from Dr. Bayokan's paper, as you can see. We are not able to make site diagnostics immediately. It's not that simple. Whether or not there is cytological atypia present. Cases without cytologic atypia and fibrovascular core are classified as negative for HGUC. On the other hand, cases with fibrovascular core classified as LGAN. I will show you the fibrovascular core in the urinary specimen of LGUC in the next slide. As you can see here, in the histological slide on the left, tumor cells proliferate on the fibrovascular core, indicating a papillary structure stained with HE. On Papa Nicola's slide, if it appears in the urine while maintaining such a papillary structure with a fibrovascular core, we can be concluded that it is LGAN. However, this structure is not found in the body of the urine sample. And this characteristic appearance is only demonstrated, such as the bladder washing sample or catheterized urine sample. And as you can see from this slide, if the cells with mild atypia, but the cause is clear, like a polyomavirus infection, etc., it is classified as negative for HGUC. Let me show you these benign atypical cells in the next slide. Here, you can see 3 major benign atypical cells were shown in this slide. Decoy cells are virus-affected cells, frequently accompanied by changes in cell morphology, which is, of course, visible in the light microscope. The other two are reactive or reparative cells, both derived from renal tubular cells and urocellular cells. Since both reactive renal tubular cells and reactive urocellular cells are difficult to interpret in a short time, so I will go into only about decoy cells at this time. As I said in the previous slide, the decoy cell is a human polyomavirus infected cell, which means the multiplication of viruses within the cell. The viruses tend to deactivate whenever host immunity is depressed for any reason, so that it especially appears in the urine sample from immunocompromised patients. The salient feature of the smear in the microscope is the presence of enlarged urocellular cells, legally detected on screening at low magnification. As such, this experienced cytologists often get mistaken for HGUC. Here, I will explain the distinguishing points in detail between decoy cells and HGUC cells. Both decoy cells and HGUC cells have a high MC ratio, which is quite remarkable. However, the nuclear chromatin of HGUC cells is coarse and dense, whereas the decoy cell is amorphous basophilic nucleus, so-called pale appearance, and thick-ended nuclear membrane. The category of decoy cell is negative for HGUC. Next is atypical urocellular cells. The required feature for atypical urocellular cell is more than a 50% MC ratio. In addition, one or more features are required from the below: hyperchromasia, coarse chromatin, irregular chromatic ring. As I mentioned before, even if you encounter these conditions, decoy cells, reactive linear tubular cells, and reactive urocellular cells are classified as negative for HGUC. If the cell atypia shows severe, it is classified as suspicious for HGUC or HGUC. The difference between these two categories is the number of cells. The required feature for suspicious for HGUC and HGUC is more than 70% MC ratio and hyperchromasia. In addition, one or more features are required from the below: coarse chromatin, irregular chromatic ring. If the number of cells showing these features is 5 to 10 or less, it is classified as suspicious for HGUC. On the other hand, in the case of presenting many cells, it is classified as HGUC. As mentioned above, the MC ratio is the most important feature of the Paris system. However, can our subjectivity determine an accurate MC ratio? Let's try the test. Which one do you think is 0.5 of the MC ratio? Which one do you think is 0.7 of the MC ratio? Please think for 10 seconds. Did you get the answer? Now I will announce the answer. This group is 0.5 and this group is 0.7. I think many people answered B or C. Our subjectivity tends to overestimate the MC ratio. Therefore, we need training regarding MC ratio. Finally, I will explain the sample preparation method. freshly voided urine greater than 50 milliliter is the most appropriate for cytologic specimens. We need an immediate process to avoid cell degeneration. In leaving for a long time before fixation, the addition of the fixative an equal amount of 50% alcohol as urine is recommended. In castor urine or instrumented urine specimen, many cell clusters appear in the cellular sample due to mechanical stimulation. These cell clusters look like elegant at first glance. Therefore, it points to the critical need to know how cellular sample has been collected. If the urine is left unprocessed, the cells will settle on the bottom of the cup. If urine is dispensed into a test tube, as it is, cells will not enter the test tube. Therefore, stir the urine in the cup with a spoon to make it homogeneous. Otherwise, the cells will not enter the test tube. Next, I will explain the number of cells due to the difference in the sample preparation method. Both slides were made from 10 ml of the same voided urine. In the conventional method, most cells exfoliate to the fixed solution. Some laboratories perform ginger staining for urine cytology. However, since urine has proteins, excluding severe hematuria and proteinuria, drying destroys cells. We can preserve the cell morphology by adding albumin to the sediment with the same samples. As mentioned before, urine has protein. If slides are wet fixed in 25% alcohol, Dr. Boone reported that 74 to 98% of cells are lost. If cells are dried by the air for ginger staining, it makes cytolysis, exclude hematuria and proteinuria. Therefore, I can recommend this method. Regarding the sample preparation method, I recommend the Barrett method and the Uropathology method. The reagents required for the Barrett method are alcohol and polyethylene glycol. In addition, it can be carried out if there is a centrifuge. Although the Uropathology method is liquid-based cytology, it can perform manually without expensive equipment, and you only need a centrifuge and an aluminum rack. First, I will explain the protocol of Barrett method. Stir the urinary sediment obtained by the first centrifugal separation. Add a fixative to the sediment. Fix it for about 10 minutes. Then, centrifuging it again. Next, put the sediment on the slide. Then allow sediment to spread between two slides. After that, dry it naturally. This drying operation is a critical point of our method. The drying operation prevents cell peeling from the slide. On the other hand, the cell surface is coated with polyethylene glycol and does not dry the cells. Next, I will show you the SurePath LBC method, which is commercially available. But I don't know if this device is available in Mongolia. The instruments required for the SurePath method are lugs and a centrifuge. This aluminum lug is about $500 US, but you can buy a plastic one for about $50 US. In addition, as consumables, it is neither settling chamber and positively charged slide. Using this slide, I will explain the principle of the SurePath method. The principle of the SurePath method is gravity segmentation and electrical adhesion. The cell suspension adds to the chamber. It rests for about 15 minutes. The cells are settled on the slide by gravity. The cells are charged negatively, so they combine with a positive charged slide. The SurePath slide shows many cells in the tiny smear area, as you can see here. Therefore, I recommend the SurePath method because it is inexpensive and provides high-quality urine cytology specimens. If the time comes for you to use the SurePath device in Mongolia, we are interested in working on joint research with Dr. Bachman and her associate. And of course, we are willing to cooperate with all of you gathered here as well. Here is my last slide. Let me briefly summarize the main points I have talked about today. First, in the urine cytology overview, I showed you the advantages and disadvantages of urine cytology, and why the Paris system was created as its central object for urine cytology. The ability to detect high-grade urocell carcinoma. Second, I showed you the categories and cytomorphology criteria of the Paris system. Third, I explained Barr's method and the SurePath method. As I said to you at the beginning, you should understand the basics of urine cytology. To put it another way, if you don't understand the basics of urine cytology, you can't begin. This is a highly critical process. Last, but certainly not least, it would be my pleasure if my lecture could be a catalyst for the use of urine cytology by Mongolian uropathology professionals. That's all I have to say. Thank you very much for your attention.
Thank you very much, Professor Hiroki Kawasaki. And манай орцогчдоос ерөнхийдөө асуулт байсан бол мессенжер хэсэгт чат хэсэгт бичээд үлдээгээрэй. За тэгээд ерөнхийдөө өнөөдрийн одоо энэхүү вебинар хуралд маань ихтгэл хэлцүүлсэн Hiroki багштай бас их баярлалаа. За дараагийн илтгэлийн хугацаа маань ерөнхийдөө нэлээдгүй шаардсан учраас үргэлжлүүлээд профессор Альфриг одоо урьж байна. За thank you, Professor Osaki. We are appreciate for your great presentation for us, and I hope our participant could understand urine cytology for the basics. So we are just off the time for the next lecture. So please understand our sincere, grateful appreciation for your participation. I hope our participants will send questions about your presentation for the next time. I will send you by email. Thank you, Professor.
Thank you. Bye. Thank you so much.
Thank you. За манайхаа. За дараагийн профессор маань Герман улсаас холбогдож байгаа. За бид бүгдийн хүндэт профессор Йохан Альфер байгаа. За Альфер багш манайд бол та бүхэнд төрөө булчирхайн биосины талаарх онцлогооны ойлголтуудыг танилцуулах болно. За ингээд профессор Альфрийн лекцийг оруулъя. So please welcome Professor Apple. Could you please share your presentation for us?
Yes, I will do. Can you see the presentation now?
Yes, we are.
Fine. Okay, I can go straight ahead, I guess.
Yes, please. Dr. Linke is ready.
Thank you for inviting me and for organizing this symposium. I would like to thank special thanks to Director Oyanga and her staff. It is a great pleasure because it is an ongoing meeting which started formally in 2008 as a German-Mongolian presentation, a kind of spring meeting organized by Professor Galzok, Orjan Erdene, and Professor Peter Röttger. What you can see here at the first slide is one of my institutes. We have several institutes. It's in Ravensburg, the institute, the little one, and the great clinicum behind. My pleasure is that I have now simultaneously translation, so I will have to be more slowly, I guess, in presentation. So the first slide is why is Gleason grading a key benefit for the diagnostic of carcinoma of prostate? It is less dependent from artifacts, and the heterogeneity of prostate carcinoma is reflected by the Gleason pattern, and it's a great international acceptance. So these are very important benefits. Also, Gleason great correlation with pre-therapeutic PSA, TNM stage, tumor volume, lymph node status, and other prognostic factors like ploidy and angiogenesis, the relapse and survival rate. The Gleason grading system is intended to be applied primarily at low power, so don't go to high power looking for one or two fused glands. Indeed, in the end, you will do that, but starting not with a high magnification. You should visible at magnification 100 to start with. The Gleason score is the sum of two most prevalent patterns subject to the following. So these are basically the strategies for analyzing prostate cancer. So for core needle biopsies, the predominant pattern is given first, and the second most predominant pattern is given second. For example, Gleason's score 3+4. So the pattern 1 and 2 will never be named in a biopsy because you cannot do this diagnosis because the tumor rim is not visible. So if the tertiary pattern is higher than both of the first two, it becomes the second pattern, regardless of its prevalence. So if you have just 1%, it will be named. So for example, 3+4 with tertiary, a third pattern 5, it becomes 3+5 in a biopsy. So you have to indicate the most and the worst pattern. So the generally Gleason rules are for grading are only one primary grade in core needle biopsy. So double the first one. So for example, 3+3 is 6. Secondary grade should be minimum 5% of tumor mass. So pattern 4, the most, and 3, the secondary pattern, if it is more than 5%, it's 4+3. So not indicating the most and the worst, because if you have 4+3, the most and worst would be 4. But depending on the 5% rule, you have to name also the pattern 3. But if it is less than 5%, you will have to say 4+4. So Gleason 3+4 is 7 and indicates tertiary grade in prostatectomy and TURP, but tertiary grade higher than primary and secondary grade is necessary. For transurethral resection of prostate, so for TURP, the complete embedding of the tissue is necessary if the weight is less than 12 grams. If the weight is more than 12 grams, for each 5 grams more weight, embed one more block. So that is a rule. So you have to, you know, that it is necessary to embed more tissue if you have more mass. If you are in doubt, you will have to complete embed the tissue, especially if you have a young man with a little tumor inside of one specimen. So you should embed all to get the complete overview. Maybe it is more than, in the end, PT1A, maybe PT1B, and more than 5%. So PT1A of the tumor volume is less than 5%, and 1B is more than 5%. And you get the best overview for embedding all if you are in doubt. The tertiary pattern should be determined, of course, and the tertiary Gleason pattern included into the Gleason score when it is more than 5%. In the case of PT1A, embed the rest of the tissue to exclude the one PT1 situation. So pattern 3, a single glance of variable size and density with an infiltrative pattern, each separated by at least a strand of stroma. That's pattern 4. Critical distinctions from higher grade carcinomas are the widespread presence of well-formed lumen and the lack of few strands. This is a common pattern of low-grade carcinoma. Now here you can see tumor glands, tubular, growing beneath the typical hyperplasia glands of the prostate. And it's growing normally, the pattern 3, between the hyperplastic glands. Pattern 4 are cords of fused glands. Minimum 4 fused glands are recommended. Poorly formed glands include small nests of cells, only a rudimentary formed lumen space, almost rosette-like. Intracytoplasmic lumen do not count as pattern 3, they are 4 or 5. Fused glands are recognized as back-to-back glands without intervening stroma, a cribriform pattern, and the quantification of pattern 4 is almost necessary. So almost indicate the percentage of pattern 4, even if it is a semi-quantitative rule, but it is necessary in the end, you will see. I hope I'm not too quick for translating. So Gleason grade 4, also mucinous carcinoma are Gleason 4 glomeruloid bodies and clear cell hypernephroid tumors. This is a typical Gleason 4 pattern of the prostate with cribriform growth, and the mucinous carcinoma is mostly a grade 4 because of cribriform growth of the tumor. As you can see here, if you remove the mucin, you will have the pattern of the growth pattern of the tumor, and also it is a Gleason grade necessary, but mostly it is grade 4. And here you can see now a hypernephroid tumor. It is so glomeruloid tumor growth, so the glomeruloid pattern, and very rare. I have rarely seen this pattern, but it is a Gleason pattern for the glomeruloid pattern. Pattern 5 is erect infiltrative single glands, cords or sheets without glands formation, small solid cylinders of any pattern with chlamydomnecrosis is pattern 5. So take care of chlamydomnecrosis. So Gleason grade 5 is a syndrome-like cell variant and the sarcomatoid carcinoma. Transitional carcinoma should not be graded by Gleason. Here you can see a single cell carcinoma, very little lumen looking like, but it is positive for mucin, and diffuse growth with mitosis here in the middle visible. And this tumor is typical positive for CDX2 and for PSA. So if you don't know whether it is a kind of metastasis, it is PSA positive, looking like also the signaling cell tumor of the gastric cancer, but it is positive for PSA. So prognostic category, Gleason score 6, often diagnosed in corneal biopsies, and it is called the ESOP grade 1. Prognostic category, Gleason score 7, often diagnosed in corneal biopsy. So if you have 3 plus 4, indicate the percentage. It's ESOP grade 2, and 4 plus 3, also 7, but ESOP grade 3. And as you can imagine, that it is necessary to know the percentage. It is different to know 3 plus 4, 45%, or less than 5%. Makes a difference, not in the ESOP grade, but in interpreting the tumor growth and tumor mass with pattern 4. Prognostic category Gleason score 8 to 10 is relative seldom diagnosed in core-needle biopsies, and it is a high-grade carcinoma. Gleason grading generally rules are for ESOP group grading 2 and 3 is Gleason score 7. Percentage should be indicated as I told you, so you can see the difference is not visible by the Gleason score or the ESOP grade, but you can make the difference with the percentage indicating. So generally rules are cribriform pattern and comedonecrosis are pattern 5. Take care, intraductal carcinoma with comedonecrosis and no grading is allowed. Bad quality of glands. You should perform serial sections to get a better quality because that is very important for the diagnostic of the biopsies. So if you have a bad quality, try to perform better serial sections. Higher grade tumor with less than 1 millimeter in size, the grading should be conservative. You have to take care. But nevertheless, we do make the diagnosis even of less than 1 millimeter tumor in size. MRT or MRI biopsies of suspect lesions, PIRATES 4 and 5 with benign diagnosis have to be reported. Nowadays, we have often MRI biopsies, maybe 4 or 5 biopsies of one region, and even if it is benign, you should report it. No Gleason grading is done for metastasis and also for treated carcinomas, like also for the breast cancer, for example. So regressive changed carcinoma after radiation or even androgen ablation. No Gleason grading is also done for small cell carcinoma, for basal cell carcinoma, urothelial carcinoma of prostate, and squamous cell carcinoma of prostate. So an overview here, you can see the grade group and the Gleason score and pattern. Report both in the biopsy report diagnosis. So the summary of ISUP 2019 modifications to prostate cancer grading are as follow. Report in biopsies the percentage of Gleason pattern 4 for all Gleason score 7, as I told you before. For radical prostatectomies, include the percentage of tertiary Gleason pattern 4 and 5 in the Gleason score, if consisting more than 5% of the tumor volume. Do not grade intraductal carcinoma without invasive cancer. Incorporate the grade of ETC into the Gleason score when invasive cancer is present. Comment on the presence and significance of intraductal carcinoma in biopsies into radical prostatectomy specimens. Comment on the presence and significance of invasive cribriform cancer biopsies and radical prostatectomy specimens. Report in systematic biopsies a separate Gleason grading for each individual site biopsy. So, as I told you, for each biopsy, it is necessary to make a Gleason score, and we do it also with a percentage. So, report in MRI targeted biopsies a global aggregate Gleason score ISO Gleason grading for each suspicious MRI lesion. Report specific benign histologic findings in suspicious MRI targeted biopsies without cancer. How to manage prostate biopsies. So, for example, in Germany, we have very often 18 core needle biopsies of prostate, so 9 biopsies for each site. Each biopsy embedded in a single paraffin block, and the location is also recommended. So apical, lateral, posterior, and so the biopsies are located very and described. Each biopsy with HE staining is necessary. Serial sections, maybe until 6 on one slide, are recommended, and 1 slide blank for immunohistochemistry if you need it later on. Because if you have a biopsy with only some few tumor-looking glands, you can look for immunohistochemistry, because the serial section is visible, and you can need it, for example, for immunohistochemistry. Microscopic description for each biopsy is necessary, and each tumor infiltration of a biopsy will be reported. So percentage of tumor infiltration of biopsy, well, it's semi-quantitative. For myself, I can measure it, and it is more clear, but it is recommended to do this. Also, Gleason pattern is recommended. So the report in Germany is like bilobular adenocarcinoma with tumor in 4 of 9 biopsies right side and 6 of 9 biopsies left side, with perineural infiltration in 1 biopsy, for example, left side, without extraprostatic tumor growth. So also also describe whether there is a perineural infiltration and extraprostatic tumor growth, yes or no. So MRI targeted lesions should be also described separately, with and without tumor infiltration. If 4 biopsies are sampled out of 1 MRI lesion, it is reported as 1 infiltrated region. That's important for the clinicians. If they have only 2 regions with tumor, with, for example, Gleason pattern 3+3, you will make a watchful waiting. The Gleason score, all biopsies together are 3+4, and, for example, 10% pattern 4. WHO group is 2, or ISOP group is 2, PT1C, PN1 left side, and ECDO 8140/3. So the microscopic description, I was asked to show this, how do we manage it? It is the microscopic description of prostate needle biopsies. Each biopsy will get the region where it is from, the biopsy length, the tumor infiltration %, and the Gleason pattern. So if you do it for all 18, it will be possible for you to add all the Gleason 4 percentage and make a mean, and you know how many percent the Gleason pattern 4 is in the whole amount of biopsies. So it is easy to get the percentage. Also for MRI targeted lesions, every single biopsy has to be described, but altogether these biopsies are 1 region, so that's important. And here you can see now the tumor growth of a core needle biopsy from prostate, the tubular growth here, and you see these cells are fat cells, and you can be sure you are beyond the prostate capsule. So it is extraprostatic growth of the tumor, and you have to recommend this. Perineural infiltration should be recommended. And here you can see some clear cells, so clear cell change of foamy gland type carcinoma. Is it a foamy gland type carcinoma variant? Yes or no? The immunohistochemistry shows you, yes, there's a perineural infiltration, and this is a foamy gland carcinoma variant in a adenocarcinoma. So foamy gland type adenocarcinoma is typically found as a component of adenocarcinoma. And I have never seen it. Is very pure, rare. A pure foamy gland carcinoma is very rare, with 0.2 until 2% of cases. So I have never had a pure foamy gland type carcinoma till now. If you see this in a corneal biopsy, you see, well, it is an infiltrative carcinoma. And here, this, you're not sure, maybe is it a cribriform pattern, or is it somehow intraductal? Are there basal cell layers around? If you make immunohistochemistry and you have a second cut of the biopsy, you will get also then this lesion, and you can see it is an intraductal carcinoma of prostate. Atypical nuclei are visible with prominent nucleoli, and racemase positive, Amaker positive. And therefore, it's an intraductal growth of an invasive cancer, and therefore different compared to disease in breast. You know, if you have a ductal carcinoma in the breast, it is possible to be without invasive cancer, but intraductal carcinoma of prostate is an interductal growth of the invasive cancer around. Sometimes it's also some regions looking like this. Here it's looking like, yes, it is. Is it intraductal? Is it a atypical growth? The nuclei are not so atypical looking. If you make immunohistochemistry, you see that it is Amaker negative. It is clear cell cribriform hyperplasia. Also, a benign lesion is what you see here. It's looking like tubular growth, very suspect maybe. And if you make PAS staining, you see it is positive. And if you make immunohistochemistry, you see it is positive for P63 and negative for Amaker. These are Cooper glands. So a benign lesion. You have to think of these lesions if you read the biopsies. So thank you for your attention. I hope it was not too quick for the translating, because I have no feedback what the translating is stopping, yes or no. So thank you very much once more.
За маш сонирхолтой. За ингээд сонирхолтой ихтгэл танилцуулсан айлбар эмчтэй баярлалаа. Дашрамд дурдвал энэхүү одоо сургалт вебинар хурлын маань зохион байгуулахад бас хэд хэдэн байгууллагууд хамтран оролцож байгааг хэлмээр. За үүнд бол эрүүл мэндийн хөгжлийн төв, Pathology, Uropathology, ХЯНАЛТ, ОНОШИЛГОО, ВЕБИНАР, анагаахын шинжилгээ ухааны үндэсний сургууль, эмгэг судлалын шүүх хөтлийн төлөвийн хамт олон мөн Монголын эмгэг эдис судлалын нийгэмлэгийн хамт олон маань бас харилцан хамтран зохион байгуулж байна. Professor Arthur, do you have any comments or for your colleagues from Mongolia?
Thank you very much for this great performance that you make here with the international conference, which is more than the Mongolian German conference before, and it is a kind of ongoing development, and it started very small, and now we have big conferences, and I hope indeed that we will be able to meet personally maybe next year. I want to, it is necessary, urgent, so to say. So I'm once more, thank you very much for your great work, your stuff. You are high and performing here, so it's really a great job you made.